So very good morning to all of you all on this beautiful Sunday morning. We come back to you again with another one of our webinars, and this time it's a very interesting one. The topic of this webinar is arthroplasty after acetabulum fractures, and today we have one of the pioneers of pelviacetabular surgery and of joint replacement surgery with us, Dr. Ramesh Kumar Sen. Dr. Ramesh Kumar Sen is the Senior Director and Head of Institute of Orthopedics at the Max Hospital, Mohali. He's a former professor of orthopedics of PGI Chandigarh and also an adjunct professor of the Punjab Engineering College, Chandigarh. He's a member of AO International Pelvic Expert Group. Dr. Sen has multiple awards and orations to his credit. He has been a guest faculty at the AO as well as been a national and an international faculty. He is also the editor of the trauma section of Indian Journal of Orthopedics, has published widely, has given more than 200 international lectures and almost 500 lectures in India. He has been the organizing secretary for multiple conferences on pelviacetabular surgeries and has served as the president of many associations and has been a senior examiner of orthopedics at multiple hospitals in India and across the world. He is also a visiting professor of the University of Mainz in Germany, of Detroit in the US, and of in Richmond, Virginia, and Sunnybrook Hospital, Toronto, Canada. So with all these qualifications, it is pertinent that Dr. Ramesh Sen is the man who will speak to us on arthroplasty after acetabulum fractures. And I now request Sir to please go ahead with his presentation.
Good morning. I have been asked to talk about the arthroplasty, how the previous acetabulum fractures makes it to happen. When we talk about arthroplasty after acetabulum fractures, we understand that this will be done when the patient has got a post-traumatic arthritis or a non-union or a malunion. It may be after an operative treatment, it may be of a non-operative treatment. And in some of the times in an acute acetabular fractures, when we expect the result of any surgery is likely to be poor, and especially true in the elderly age group, we do arthroplasty in a situation of acetabulum fractures. What is difficult about these cases if they have not been earlier operated? There is likely to be distorted anatomy. There is likely to be a significant bone defect. The femur head may be subluxated or dislocated. The walls of the acetabulum may be displaced, and the femur head might have avascular necrosis, might have total lysis, or there may be heterotopic ossifications around the hip in the situation of a neglected acetabulum. If this acetabulum has already been operated upon for a reduction and fixation, and for some problem, if you are operating upon this kind of a situation, there are likely to be a problem of soft tissue adhesions, there is likely to be fibrosis. And once they're looking at implants which will be there, they might be in various directions which may need removal. The problem of the femur head might stay as avian or lysis. The femur head may still be subluxated or dislocated. And even the fragments of the wall also might have become avascular. And very important, it may be element of subclinical infection in that area. So in our preoperative workup, what we are anticipating? We anticipate more than a routine blood loss because it could be intraoperatively we have to take care of the salvage, and we must have an adequate amount of allogenic blood available for this kind of a situation. Then what could be the surgical exposure, how it differs from a standard kind of arthroplasty? Now it will depend upon how is the software around, how is our access to the various fragments in this kind of a situation, because we might have to go for extensile access into that area rather than a limited access. And then we will need a specific tools which may include the tools to take out those implants, to cut those screws, or we might have the defects also which needs to be filled up. So we should need allograft, we might use autograft. So all these things are essentially to be worked up beforehand. Another thing in this kind of a situation of doing arthroplasty is that once the normal anatomy of the acetabulum is altered, it becomes difficult to define what is the version. It also difficult to define the inclination, because there may be a wall defect, there may be a displacement of the ischium, or the acetabulum might be widened or it could be narrowed down. Another problem could be in the soft tissue because of the adhesions or a fibrosis and a contracture which sometimes develop around, there could be an issue. Another could be the displacement of the acetabulum from its normal position, which can be in a limbless discrepancy or in a offset change, which we'll have to work on this kind of a situation. And very important, if the previous surgery has been affected by infection, we might still have raised ESR or a CRP. And if there is a suspicion of this kind of an infection, we have to aspirate the hip, looked at the cultures, looked at the synovial cell count. And in this kind of a scenario, we will have to plan surgery in stages. In the first stage, we'll have to remove any residual implants, we'll have to debride the joint, and we might have to put antibiotic loaded spacer in the area. And then subsequently, when the infection settles down, we'll have to go for a second stage reconstruction. If there are osseous defects, what is their extent of involvement? This way, we will have three different kind of a situation. There will be patients where no special reconstruction is required, just like previously operated case where we have achieved a good reduction and the indication for surgery is like lysis or AVN. The acetabulum is well made, so we do not have to worry much about the bony reconstruction of it. There may be a situation where there is a minimum alteration, just like a non-union present there, and we need to do a replacement. In that situation, we just have to stabilize the acetabulum, and by stabilizing, we will have to do a standard replacement surgery. But there must be a different group where the total alteration is there in the anatomical structure, or there could be the presence of an infection. So first we talk about cases which require no special reconstruction. In this kind of a situation, let's look at this scenario. This is a patient, you see the involvement. This is a 6-year-old acetabulum fracture. And you see the changes which have been there. Now, once there is an adequate bone stock available around, in this kind of a situation, in that arthritis which has developed as a part of the neglected dislocation, there is enough of the bone around. So basically, we have to have a proper medialization, proper reaming, and then we can place our cup in that situation, which can give us a reasonably good positioning also, because the bone stock is good, and we can have a good outcome. Another situation, another 12 years old acetabulum fracture. Again, there is enough amount of a bone stock over there. So we do not have to worry about a bone stock deficiency. Rather, we have to worry about the positioning of the cup within this area. So with that kind of availability, again, it is not a big issue. So we need to define, we need to have the proper placement of the cup after a proper reaming, which way we can define the inclination, we have to define the version, and then we can do it. This is another situation, a 16-year-old acetabulum fractures, because it has not been operated upon earlier, so the subluxation stays. There is a pelvic deformity also. Now, such a deformity which has been there for 6 years may not be very easy to reduce. And in this kind of a situation, our version is very important. We will have to keep it little more horizontal, considering the tilt of the pelvis, which might be fixed by this time. So if it is a fixed kind of a tilt, then we have to go for more inclination in relation to the acetabulum over there. But as far as the bone deficiency is concerned, that is not a big issue, and that is what we can manage in this kind of a situation. But there could be a simpler thing, just like a previously operated case where the acetabular head has gone to lysis, the fragments, there must be the metal work which might have entered the area, but the acetabulum is reasonably well made. And in this situation, after removal of this metal work, we can have a comfortable reaming and a comfortable fit of the implant, as both anterior and posterior wall of the acetabulums are reasonably okay. And with this kind, you can see the follow-up also, it can go well with the outcome also. There could be another situation when there is a post-traumatic arthritis after the reduction. And again in this scenario, because its walls are well made it out, so we do not have much of the problem in getting a good bone stock, as these implants are not creating a problem. So in this kind of a situation also, we can have our cup well fitted into the area, well fixed, and this kind of a uncemented cup can give us a good outcome, like here in this situation also. Another situation, you can look at the acetabulum fracture, which has been stabilized with these two plates and anterior column screw, and with the flip osteotomy, getting a AVN, as you might perceive over here. But when this replacement is done, the same cup is used and the uncemented cup could be put. And this is his 6 years follow-up. And here we can see his 8 years follow-up. Is able to manage all his activities with this kind of a follow-up, because the bony quality has been very good to start with. Now, we have the cases which have some alteration, but no major defect. We do not have a lot of defect around in the bone. In this kind of a situation, there is a non-union of the posterior column. You can see in this view, in that kind of iliac view, where there is a clear-cut defect and a non-union of the posterior column. Now, there is adequate bone here, there is adequate bone here, but non-union definitely needs stabilization. So what we need, that we have got a stability of the posterior column non-union. Once we stabilized it, we had adequate bone anteriorly and posteriorly, and we could fit the this cup into this area. Another situation, another non-union of the posterior column and a displacement. In this situation, which is an old non-union, it may be difficult to get it back to its place. But there we are able to get a reasonable amount of a host bone to get a reasonable purchase of the cup into this area. And by putting the screw in situ, after getting adequate reaming into the area, we are able to have a good cup control into the area, with even with this displaced kind of the posterior column, and it is a appropriate outcome. And this is his 6 years follow-up of the same case of a non-union ending up. This thing, there is a posterior column which we have not touched, but the area which is required to support the cup is very well over there. Another situation, it's not a very old injury, but the patient is 64 years old. Now, in this kind of a situation, to try a 4 weeks old injury, we thought it may be better to stabilize this and to do a reconstruction. And again, in this kind of a reconstruction, we are able to get reasonable stability at the column level, and we are able to do a replacement in this situation. Now we look at the cases which require a significant alteration. It could be anatomical support need, it could be a central displacement, it could be an altered hip center in this kind of a situation. So let's look at first those segmental, cavitary, or combined kind of a defect. Now, what is important here? Here we need to support this cup with an autograft or a allograft. We might have defects where we will need a lot of graft to be put in the area, and in that area also we might need a cage or a mesh to support our graft till the time the grafts get a good incorporation, and we might need a lot of cages in this kind of a situation. Let's look at this scenario. A 4 months old posterior wall fracture. Now, if this is a posterior wall fracture, there is nothing to support. And you look at the femur head also, this is half the way depressed. So you cannot definitely reconstruct this kind of a situation. And as far the posterior wall is concerned, we need to recreate it and replant. So we use the femur head, put the femur head back, over that we put the plate, and this is the kind of the femur head support given, and a plate is put above it. So once with the availability of the autologous femur head and the plate, we can use the cup, again an uncemented cup, giving a reasonable amount of a purchase, and this is 3 years follow-up in this situation. Another case, a neglected acetabulum with that posterior dislocation, and you can see over here in the CT scan, it's totally a bare area posteriorly. So we need a bone here. So we mostly use this femur head, put it over here after properly shaping it over there, then applying a plate over this area, this extra bone formed from the femur head gives us adequate place for the cup to be put. And that is what we have done here. We have put the femur head into the area, put a plate over it, and put multiple long screw from the plate going into the posterior column, which are able to support the area in which we can put this cup into the site. And again, you can see the subsequent follow-up of this patient who is able to have a good outcome in this situation. Another case, similar kind of a situation, a neglected kind of a dislocation, but now there is a defect. If you look at this view, there is a significant defect into the posterior wall. So this posterior wall needs reformation. And again, we use this very femur head to buttress that area. And once we have buttressed it, we put a plate over this, because plate allows us to put multiple screws from the plate side, compressing the graft. And this way we are able to hold the graft, in which we are able to put the cup into this area. Another case where there is again a significant, now considering that these cases might require a cup, which may require kind of a porous this thing, which may settle down in that area of relatively host bone, which may be less than the optimum. So we need a good quality. We might need a trabecular metal cup. We might need a multi-hole cup depending upon the need, but we definitely will have to build up the bone around here. And as we build up, as we put the graft over there, we can put subsequently the cup into this area. Another situation, a 33 years old dislocation. Again, this is a dislocation where we have a lot of defect in the backside of it. Now our aim is to get this head back to its position over here and to put a graft into this area. So we put the whatever head is left, we put over this head, support it with the plate. Once it is supported with the plate, now we are in a situation to put a cup. Here the situation is not very good for the host bone. We put a cemented cup into this area, and which is very well coming over to a normal level. So we are able to maintain that offset also. Here is a case in 19 years young boy with a 6-month-old injury. Now we discussed all these options with this boy with this kind of a hip joint. Now 6 months old, he's able to stand, but you notice a difference in this side weight bearing as compared to another side. He's able to sit, but he has this abductor lurch in the gait, which he's not happy. We counseled him a reasonable number of time before taking him for surgery, that whether he can accept any other alternative like a fusion, which they were hip. So we took him for the surgery, and this was the condition of the femur at that level. We did curate it out everything. Now it was difficult to take this very column back to this place, but what we could do, we could use slice of the extra part of the head which was bad, put up into this area, and we could get this area over there, put a plate over there. After we were able to reconstruct this area, this way we could get fixed over there, this plate, enough of the bone, and then we could put this ceramic head. And this is the kind of the situation we could make in this area. So a lot of graft, we did not touch this column, but with a lot of graft, with the support of the plate, we could put it over there. And this is a subsequent outcome after 2 years of follow-up. He's relatively a happy boy now, and his gait is also improved. We understand doing an arthroplasty at this stage does mean that he might require a revision little earlier, and considering his early young age, he might be much more active than most of the other cases where we do in the older age. Now, many a time, these cases, in addition to posterior defect, will have a superior defect also. Now, in this situation, if you see, it is not only the posterior, it is superior defect also. And while in this kind of a bone graft can do well on the posterior side, which doesn't take much of the load, superior side, this graft is not likely to bear weight. And here, invariably, we require the support of the cage. This is that octopus cage which we used. And by getting that graft support to the cage, because if we do not have a graft, the cage is likely to fail early. So we impact a lot of graft, and thereover we apply this cage. And once this kind of a fixation occurs, this is 2 years follow-up. These cases, this kind of a cage become necessary in this situation. Now that was one situation of a posterior defect or a posterior superior defect. Now we look at the central displacement. Now this is a situation where the anterior column injury is there. Now this is not posterior column. Anteriorly we do not have a problem of the stability because posterior column is reasonably intact. But there is a defect here. So once there is a defect, now this defect needs to be filled. It's anterior, and very comfortably we can put a lot of graft into this area. It could be autograft from the head. So once they fill up this area, there may be such an area we might need to put even mesh to contain that graft also. Here we put mesh also, and with this mesh and this graft, we could hold a lot of graft into this area. Mesh we supported with the screw, and in which we could apply a cemented hip in this area for the fixation, and this is the kind of the short-term outcome. Another scenario, again, posterior column is displaced, but anterior column is much displaced. It is much better as far as the posterior column is concerned, but anterior column you see a big defect. Now you cannot keep on pushing a lot of graft into area. You need a kind of a mesh. So you put a graft, you put a mesh over here, and then once it is all supported, all filled up, thereafter we apply this cemented cup, and that way we ensure his ability to walk. Another situation, same kind of a situation, but very less area to contain the graft. And again, this becomes an extra situation when you need some kind of a stabilizing thing here. And in this stabilizing thing, this is the kind of the cage we use. With this cage into this area, we get a support of the cup in there with the impaction grafting. Another scenario, a badly destroyed acetabulum with a significant amount of a loose bone formation, which is not actually discontinuity because somewhere it is still united. And once it is united, but there is a big defect into this area. You can see the CT scans also over here. You can see the CT scans also. It's all destroyed area, but a malunion is still there, which is providing us a reasonable amount. So what we do, we curate it out, freshen it out. There is a defect inferiorly, we put a mesh, then we add graft, we punch them in, we subsequently keep on pressing them in. Once we do reasonable amount of impaction grafting into this area, now we can put a cemented cup in this situation. And you can see it out, how it changes this thing into an intraoperative mesh, a kind of a lot of graft, where we have been able to put a cup. This is immediately a post-operative day, and after about a month, you see how the things have changed in this kind of a situation from this area to this area, how it has gone into. Now, there is another situation. The hip center may be changed. Now, again, look at the same case, same type of a case, 28 years old dislocation. This is hip, but the hip is dislocated, subluxated. Now, considering it is 28 years old, it's very difficult to get femur head down to this area. At this kind of this thing, no amount of a release can help at that stage till we don't do a shortening kind of a thing. But here we talk to the patient, we have all the understanding. He accepted that whatever position we achieve, so we were able to achieve a position not far away from his center, but it is not ideally at the center. Considering the kind of the pelvic deformity, he is still able to have a reasonable amount of a positioning. And then there could be another difficult situation. A ilium which is broken. The posterior part has malunited, but anterior part has gone fair widely, and then it's difficult to get a reconstruction. So now we will have to reconstruct ilium to ilium, and that is what we have done with the extensile iliofemoral approach. We reconstructed this ilium to go back, put a plate here, and then with the proper version had our cup fitting over there. But we could get a reasonable bone here, we could get a reasonable bone there, and so we could put an uncemented cup to make him able to stand in this kind of a situation. Now, the worst comes the discontinuity. Now, this is what we need to realize, that this discontinuity, which happens after the trauma, is different from the chronic discontinuity which happen in the revision scenario. In the revision scenario, it is said that with the discontinuity, there is a lot of fibrosis, and if you put a bigger sized cup, a jumbo cup, the instability is changed into a stability due to the compressive effect of that fibrous tissue around the discontinuity. But in a trauma situation, you do not get that kind of a situation. Bigger the cup you put, bigger becomes the space also. So in this situation, you need some kind of a support, speaking, a kind of a cup cage construct, which provides stability of the superior and inferior fragment in this kind of a situation. And trabecular cup does help in getting the bone adhesion, bone incorporation into this kind of an area, and that is the advantage. But all of our patients may not be able to afford that kind of a situation. Now, here is a case which was an infected case, which came in this situation we took out these pins, we debrided this area, and after the debridement, we have a reasonable amount of a discontinuity. So what is the principle is to stabilizing this continuation. So we put a plate to hold this continuation, and once we have been able to put a plate, we could put a lot of graft inside, and then we applied the cage over that. So we had needed a plate, we needed a cage, so that anteriorly and posteriorly we could get a fair amount of a bony purchase across this area. Another case which has been roughly stabilized, and you can see even the trochanteric fragment, they have been taken up a kind of a approach, the older fashion approach of taking the abductors up. And when we opened it up, you can see the situation over here. The problem was when we opened it up, there was technically no abductor here. This defect was very big. So in that scenario, what we did, we added a lot of allograft into area. As a first stage, we discussed with the patient that we will do in stages. This was a lot of graft into this area, and then we used a Austin Moore over here. Within 3 months, this Austin Moore made a reasonable amount of bone, but we still kept on waiting for about 7 to 8 months. Thereafter, there was a very good healing on this side of it. Once we got this kind of healing, we put a uncemented cup over there, the cemented cup over there through a uncemented cage, which we fixed in this kind of a situation. Now, there is another situation where the appropriate care in the acetabulum fixation landed up in a problem of dissociation, and where the THR was done, but this cup again fixed into a unstable kind of a fixation, further went in and eventually created a bigger deficiency, a bigger discontinuity. From this side we reached this side. Now, while performing this side, we had to provide the stability. So first we put longer plates to hold the upper fragment and the lower fragment. After we removed these cups, we stayed on with the stem. Stem was not bad, but the cup. So we first reconstructed, added a lot of graft, and added a cage over there. And with this cage, the octopus cage, we could get this kind of a fixation, and with this fixation, we could have a patient mobilized like here. So this is what can bring a gross discontinuity. Now we have to be very careful that whenever we are doing arthroplasty, these are the patients who are in a situation where your version or your inclination may be inadequate. Now this is one that kind of a scenario where there was a significant alteration in the inclination also. And what happened? This cup did not settle down in this area and came out. So what is required is that we tend to stabilize it again. So we used, because there was a lack of bone in the superior part of also. So we used a cage here after getting a lot of graft into this area, and fixed this cage to have the stability. Another case where there was an acetabulum fracture, some fixation was done. This fixation, you can see the complication coming into acetabulum. A THR was done, but then this cup again came out because it could not get a purchase over here. So what was done? We had to use a kind of a support here. So we use this kind of we use this kind of a augment over here. Putting this augment over here, we could get a support over this here. Once this support was augmented by these augments, we could get a reasonable amount of a support the cup, and with this cup, the patient could get up and walk around, and we have a reasonable amount of a follow-up of this patient. So it is very important that cup must be securely placed, considering that the muscles which are acting over the hip joint have a lot of injuries before, and first due to the trauma, subsequently due to the surgeries. So these muscles do not retain their good quality also. So they are weaker. So the chances of dislocations are higher. And if our version is not adequate, this dislocation can occur, as happened in this scenario of a old acetabulum fracture. There was some cup which was put, but head was out. And so if you look at this area also, there is inadequate purchase of the cup. So what we had to do, we had to take it out, fill up with the graft, put a cage into this area, and this cage we did a cemented kind of a cup, and this is the subsequent follow-up. You see how beautifully the bone has formed all around here, supporting the cage also. Another case with the same kind of an acetabulum fracture, treated with some kind of a cage over here, which did not go well. Another cage was put. Again, it did not go well. But considering that he had a reasonable amount of changes, when we again went in, when we went inside, we found it out that there was an ample space here for the primary cup to settle down. So we just went with the primary cup, fixed it over there. We retained some of the old hardware, but this cup was reasonably well placed, and now we have got a 6 to 8 years of follow-up. Now we look at it when we do is a primary arthroplasty. Now the actual indication of doing primarily hip fracture is when the femur head is reasonably bad. When it is severely comminuted acetabulum and we may not be able to reconstruct, especially this happen elderly individuals and in an osteoporotic spine. It could become an intraoperative decision whenever the things look to be bad, they look to be non-reconstructible in this kind of a situation. Now, if you look at this X-ray, this is an elderly patient. You can look at the amount of impaction, amount of destruction of the femur head as well as the acetabulum. So it was wiser for us that we went inside, put these two plates to stabilize the brim, then came out, impacted rest of the graft into this area, put up this kind of a dual mobility cup, and the patient could walk. Another situation, this is again a fracture, and this is a 80 years old lady. So with this kind of a situation, we just put a cage, stabilize the cage, put a cemented cup over there, and immobilize this patient out of bed with this kind of a reconstruction over here. We have already done more than 172 patients. We had a follow-up of more than 6 months in 116 patients. And this is the kind of the age profile. We had all the young patient as well as 80, 82 years patients, also a different kind of a profile. When we looked at, according to the fracture site, this was the classification of the fractures which they have started with it. And you can see what is important. Posterior wall fracture being one of the most common things, and transverse fracture were one of the most common things, and then followed by polycumbular fractures. Extra, we used allografts in 12 cases, we used cement plus bone graft in 19 cases, but in 21 cases, the autograft was sufficient enough for them. There were 43 cases which had not been earlier operated upon, 64 had been earlier been operated upon, and we did primary THR in 9 cases. The indications were 14 had AVN, 14 had AVN plus arthritis, some cages, but post-traumatic AVN, one of the most common cause, whether it was due to surgery or it was a non-surgical trauma, it was there. Then we looked at them, how the cemented were there. We had 67 uncemented and 33 cemented, and a hybrid in 16 cases. We had an infection which led to revision in 3 cases, the dislocation led to revision in 3 cases, and some other problem were there in 2 cases. When we look at Harris hip score in these cases which have been operated upon, this varies from 78 in a cemented group to 90, and somewhere around 88 to 90 in the uncemented in the hybrid group. Maybe there may be bias because all our cemented cases were relatively elderly patients where the bone quality was poor. There we had gone to cemented. So when we looked at the quality of life also, again the cemented people with the cemented hips had relatively less, about 80 as compared to 85, 90 in the other kind of a hybrid or a uncemented kind of a situation. We wanted to see whether the positioning, whether the version affects it for parameters of the offset of that reconstructed acetabulum. And then we made it a point to see that whatever the things do not lie within the 20%, we will not take it as an acceptable level. Then we found it out the amount of labor discrepancy. None of the patients had more than a 2 centimeter, but there were some with less than 2 centimeter discrepancy, more than 1. And we looked at whether this difference between this and did not make a difference, neither in the Harris hip scores, nor is the physical and mental component of the SF12 scores, nor in the WHO quality of life score. So practical speaking, this amount of a offset change had not affected the outcome in any of these cases. We did publish our data of our quality of life in these patients also, and we found it out that they are reasonably okay. If you look at the mean value, it is around 84. The range has gone from 56 to 100 in these cases. Then we did publish another data also, and there we found it out in another paper that whatever is the outcome at 2 years, it becomes much better after 4 years. So there is a significant improvement in the years to come as the muscles also try to regain their strength after an initial trauma, then the another surgery, and then the another surgery. So when we look overall, we understand that our cases after the acetabulum could be a standard kind of a case, but with the previous reconstruction, there may be implants, there may be adhesions, which require the care in taking care of those extra things. And then there could be cases where there is a minimal alteration is required, like a non-union or like a defect which can be settled, and there could be a significant alteration. It could be the anatomical support, it could be the medial support, or there could be altered hip center. But each patient will require its own assessment as far as the bone defect is concerned, as far as the proper alignment is concerned. So every case has got its own problem, which needed to be cared to define the procedure of replacement in that kind of a situation. Thank you.
Thank you, Professor Sen, for such a wonderful presentation. It's such an extensive overview of these conditions, and your experience and the variety and the depth of cases is truly amazing.
Thank you.
And
now
we would have Dr. Vaibhav Bagadia, who is arthroplasty and trauma reconstructive surgeon at the Reliance Foundation Sir HN Hospital. He is also the president of Indian Society of SICOT, that is SICOT India. And today is our in-house expert who is going to be conducting the question and answer sessions for Dr. Ramesh Sen's presentation. So I hand over the proceedings to Dr. Vaibhav.
So as I said, Professor Sen, it's a wonderful presentation. And I'll start from very basics. So for any beginner who is trying to do these cases, who have done total hip replacements, but is planning to do a more complex type of hip replacement for these acetabular fractures, what is that he needs to plan as a day prior to the surgery? What all things does he need to kind of checklist or tick boxes before he actually goes and does the surgery? Are there any specific investigations you would wish in terms of blood parameters, CT scan? What would be your advice to them?
Yes, a very important perspective of an acetabulum fracture is the alteration in the anatomy. As I said, because when we talk about a hip replacement, we always talk about an offset, we talk about an inclination, we talk about all those things. Now, in an acetabulum fracture, this is the basic change. Here, things must have been totally different. We cannot rely upon the standard aids which are available to us, like a TAL and other parameters of the acetabulum. So CT scan assessment is very important. In addition to whatever radiographs we do, a CT scan to assess the amount of bone available, the kind of a version after the alteration is present there, the kind of defects we are likely to encounter. This is in those cases where surgery has not been done. But in all those cases where previous surgery has been done, our problem in addition to that is that there will be metal work available. This is already instilled into that area. So whether this metal work is likely to affect our surgery or not, that will be the another area to work upon the CT scans and to define it out, which screws can be taken out if they're altering, and which approach will be required to take out those implants, because there could be an implant put up from the ilion approach from the inside of the brim, and we may be doing a surgery from the outside. So we will have to be ready with the specific kind of those cutters available which can cut if a screw is coming around, or if a bigger plate is around, we might have to revise the surgery from inside and then to go to outside. So that is the basic thing. Now, in all these cases which have earlier surgery, definitely, as I said, looking for infection should be very, very important, because one of the causes of the failure of surgery could be a low-grade infection. So we must work upon that point also. So these are the essential things. Subsequently, understanding that our surgical approach, whether it is able to give us an adequate access to whole of the area or not, whether we can correct the deformity or not. So we will have to do adequate amount of a planning for reconstruction also. And likewise, what is the kind of a bone, host bone we are likely to retain with, whether that bone will be able to give us a viable base, or it is likely to be a not so kind of a viable host bone. So that is also to be assessed to define what kind of a cup we are using. Again, in the cup also, if we look at, we might have to use those trabecular metal cup if the host bone is too less, it's not very good, or we might have to do a lot of impaction grafting to have, and then we might have to go for a cemented cup. So all these things will need to be worked up if we are beginning to do this kind of a surgery. So it is definitely is not a normal surgery. It's much more difficult than a standard THR, where we have to think much more like a not like a truly hip replacement surgeon, but like a trauma surgeon also. So we have to be a mix of a trauma surgeon plus an hip replacement surgeon.
Yes, sir. Now, so if I can summarize your answer, a CT scan is usually mandatory for these patients. You
Surely,
should
sir.
also get an ESR and CRP done,
Yes.
apart from any clinical suspicion of the infection.
Yes.
Do you ever aspirate these hips preoperatively in case of doubt of infection under CR?
Yes. Whenever we are not very sure about the why the previous surgery has failed, we invariably go for that workup also, because there is always a doubt. You can never see why the lysis has occurred in a hip. So one of the causes is a low grade or a subclinical kind of infection, which many times incidentally we don't have a high ESR or CRP also. So these are the cases where we have entered the joint, we have aspirated it out, and then we have done nuclear scans also for any kind of activity. So definitely that remains, because it can alter your result at the surgical table also.
And now coming to the inventory planning. For a beginner, I mean, it's always the question of ordering too many things and not ordering enough. So what's a general take on what is the basic minimum that you should order, and what all things that you should keep as standby in case you are planning a difficult reconstruction? And I'm not talking just about implant, but also the instruments part of it that you think are sort of required when you approach these difficult cases.
Yes, the first thing which I said was that whether it has been earlier operated or not operated, because that makes a need for a specific inventory. If there has been previous metal work, now we need those inventory to take that metal work out if it is required. So one factor is that. Second factor is anatomical, whether it is, as I grouped into three main things, whether the anatomy is changed, whether it requires a minor kind of a fixation and alteration, or it requires a major change. So we must define our cases accordingly. In a simple case where the bony defect is not too much, we can definitely be comfortable regarding these things. But if there is a significant amount, now in that scenario, we might need an acetabular plates also. And whenever there is a discontinuity kind of a problem, if possible, we must have a trabecular cage also, and then we might need a kind of a metal work to stabilize them. We might need a mesh to support the graft, and all those things may be needed. So we have to group our patients according to the difficulties that are likely to be encountered, and our armamentarium will accordingly change.
So again, so as a someone who is approaching the case, they have to think in terms of defect and stability.
Yes.
If you can just generalize, if it is only the defect that they are looking at, or they are looking at defect and stability, or only the stability part.
Yes.
And depending on that, their ordering of implants would change accordingly.
Yes, that's very important.
And you said about removal of, metal cutting instruments. So
Yes.
Can you just brief, because most of the people will not have an access to metal cutting implant. Is there a specific company, or do you order it from the implant companies? How do you go about these metal cutting devices?
There are two things. First, if we are looking at the bigger implants, so it will be better to take them out either in the same surgery or in a different surgery if they are in a different approach. Just like if there is an implant which is inside, as we use a elongational approach, as we use Stopa's approach, and those screws are getting inside it, it may be wiser to go to that side and take out those screws, because whatever the tools we are using, we may not still be able to take out those screws from the other side. What we have done is that those cutters, the specific kind of a wire cutters which are relatively not big enough in size but can get into the joint, and some of the screws can be cut, are very useful. That is what we tend to keep in our armamentorium, because very big cutters are not possible to be used during the surgery, but small cutters which are of a good quality and which can take the cut into that metal, that is what is more important. We always keep in these cases.
Great. So, coming to some more fundamental questions, sir. Now, is there any broad guideline when to use a cemented cup and when to use non-cemented cup? Do you have any preference for
Yes.
either of the two, and when to use one over the other?
Yes, the choice is always for a uncemented cup if it is possible to do. Meaning by we have good antero-posterior stability possible for our cup. Then we have adequate host bone. We say it more than 60% or 70%. If we've got a good highly porous cup like a tantalum material, we can come down to 50% also, or maybe to 40% also. But two things very important: a stability of the cup and the amount of a host bone. If they are good, we will definitely go for uncemented kind of a fixation. But doing that uncemented fixation is totally a grafted bone probably could be a difficult situation, and especially when there is a significant defect and it's all a graft, impacted graft. In this situation, we tend to go for a cemented cup. So we understand from the defect size, we understand for the kind of the graft we are putting in, and if we are using a cage, obviously we are looking for a cemented cup kind of a situation.
Okay. So when would you accept a high hip center in such cases? So if there is a choice between using a less covered cup or going high hip center, is there any algorithm in your mind when you are deciding between a high hip center, compromising vis-a-vis compromising the host bone and the construct that is there? So when do you think of high hip center?
We look at actually the deformity in the spine along with the pelvis. If those deformities have already been fixed, now in this kind of a situation, it is very difficult to come down this kind of a situation, and whatever is nearest to the best possible, we will have to accept at that stage. Second thing is, we can do in a dislocation kind of a situation, we have got a chance that we can do the femoral osteotomy and can get the hip down into this area. But with the old injuries of a 28, which is traumatic injuries, which have got a reasonable amount of a fixation, where more than 2 centimeters of lengthening is not possible for the sciatic also. And that could be a difficult situation where we may not be able to get to the right center. And if we are staying within 2 centimeters of the original hip, we tend to make it acceptable in this kind of a situation.
Would you ever do that for just improving the coverage or improving the host processes thing?
Usually that is not a problem, but we have seen it out. We do change the inclination as far as I have shown in one of the cases also. The inclination you can vary, because eventually you're looking at the risk of dislocation in these cases if you stick to the original bone. So you can increase or decrease by medialization of the cup. So inclination you can change. As far as coverage, you will use all those parameters, you will use augments in this kind of a situation.
Okay. I presume that you have done most of these cases with a posterior approach.
Yes.
For these things.
Yeah, my perception is this posterior approach, being extensile, gives us a reasonable amount of access to the superior part of the ilium also, as well as inferior to the ischium also. And primarily because the loading happens to be on the posterior side, and our most of the fixation and the augments need to be put on the posterior side, so we can feel much better in that kind of approach.
Yeah. And do you need to do trochanteric osteotomies occasionally for even when you're approaching posteriorly for certain cases?
I don't think we ever did osteotomy, but it is one of the tools required. If possible, if you need to, can be done, though I don't think we have ever used it. The kind of exposure which usually happen in the posterior, you are able to get a reasonable access even without at least we could get it over there. I don't think we ever needed a trochanteric osteotomy.
Okay. And any tricks for central fracture dislocation where you have to, where it's difficult difficult to dislocate the hip, and you are trying to kind of take the head out, and you are not successful. So
Yeah.
are there any tricks in your bag to kind of
Yes,
help?
that has been a common situation. What we do is we do in situ osteotomy, and once we do the osteotomy, we are able to rotate the femur, and then we can get into the head and take it out. It is not always possible to take that femur head out of that position of protrusio. So it's better to do a osteotomy in situ position and then rotate it out rather than doing any more osteotomy. Now, second issue comes with these anterior fractures is that posteriorly we don't have a defect, it is the anterior defect. And sometime you have to stabilize the anterior side. One way, if the posterior is intact, is we push a lot of graft and put a mesh into the area, and through the mesh to the upside as well as the lower side into the ischium, and create a kind of a anterior wall. Some of the cases we have used a plate inside, using a semi-tubular kind of a plate, fixing one screw into the superior part and fixing another screw into the anterior to the pubis as well as into the ischium into the anterior inferior part. So that way creating a kind of a anterior wall in these situations where we can subsequently put our graft, support our mesh, and that way creating a continuity, because we know that this is not the weight bearing area. It is a kind of a support to the weight bearing area, which is the primarily posteriorly. So we need some kind of a support. With this support, our posterior stability also is maintained well. So that is the way we have been doing these cases.
Very good. So one of the other interesting things that you brought about was how the use of jumbo cup for an acetabular defect is different when you are just dealing with a defect and when you are dealing with instability or unstable columns.
Yes.
So you have explained that, but could you, for the benefit of all those listening, highlight the difference when you are just dealing with an acetabular defect and vis-a-vis when you are dealing with an unstable column?
Yes.
And how the jumbo cup use is different in these two things?
Yes. Now we understand the philosophy what Peprosky etc. has given is that in a chronic, when we are doing a revision scenario and then there is a chronic kind of a discontinuity, there is a reasonable amount of a fibrosis which forms around it. Being a chronic procedure, and with this kind of a fibrosis, when you put a jumbo cup, this expands, but due to that fibrotic nature, it recaptures that total cup into that area. So it becomes a kind of a fixation with the compression of the upper and the lower parts. In a trauma situation, it is no fibrosis. And once there is no fibrosis, there is a soft tissues, and bigger the cup we are putting it up, bigger it spreads around. So at no point it gives us that stability between the upper and the lower fragment until unless we do not stabilize it by our implants. So that is the basic deficiency. There is no fibrosis which is holding the superior and the inferior.
So unlike the normal use of jumbo cup, whenever you have an unstable pelvis or when you feel that the columns are not supported, you would rather go for a cage than going in for a jumbo cup. Am I correct in saying that?
Not basically a cage. First, reconstruction of the column.
Both, either a reconstruction of a column or a cage construction.
Yeah.
So in a way, so the jumbo cup will not provide stability enough in such situations.
Yes, that is very important. Very important.
Excellent. And now, so when we look at cages, there are APCs, anti-protrusive cage, and there are Burr-Schneider cages, and there are also newer designs of cages available. What's your favorite, and how to choose among these different cages that we have? And is there a different scenario in which you use a particular cage vis-a-vis the other?
Yes, this is important. First thing is, no cage will survive till it is not supported by a good graft. That's the first thing. Because cages tend to fail in 5 to 6 years of time. They do have a life if they are not supported. It is the eventual graft, the bone thing, and especially preferably if it is a autologous graft, which settles down there. Even the banked bone also tends to fail in 5 to 6 years of time if it is under stress, if it is under loading condition. During the incorporation of the graft, whenever there is a change, these grafts also fail if we are using a allograft. So what we want is any cage which should be able to support our bone graft and eventually we are looking at the bone graft to support the cage also. So whenever we have got a discontinuity or we have got a defect, so if there is a posterior defect, we want to put a bone, but we want to support this bone with the cage. Now there are two things. One is a Burschnieder type of a cage, where we have the inferior arm going into the ischium. The problem with that kind of a cage is they are not very well contoured. So you will have to first contour according to the defect, according to the superior wall. And that needs two things. They may not really fit well into that scenario. So again, you will have to have because their sizes are two sizes available only. So they may not fit into everything, and you will have to have the rimming done to that level that you can fit that kind of a cage into that area. And then it has to be supported well with mechanical fixation as well with the graft also. And whatever the position you get of stability, then you can alter the cemented cup within it to provide a stable kind of a inclination for the cup also. We have been able to prefer the other cage which has got the protuberance, which can either have a fixation down there with the screw or a curved kind of a arm which goes into the obturator foramina, and that way it is able to get up into its upper two arms are able to hold the ilium. That cage is supposed to be better, but again saying it, these cages, they need further a support from the columns which are primarily placed with the plates. So I am much more in favor of a reconstruction of the column with the plates and then cupping and putting up these cages, because till we do not maintain bone-to-bone continuity, these cages cannot help us out. So we maintain bone-to-bone continuity, we adequately put a graft, and then we support the cage. So that has to be the principle. If cage alone is put, there are reasonable chances that this cage is likely to fail. That's my take on that.
So the winning combination is both biology and biomechanics.
Yes,
as always in orthopedics.
Yes, that's true. That's true.
Sir, final two questions. One,
please.
Do you routinely use teriparatide, or do you see a role for use of these teriparatide?
In elderly patients, and especially most of them being osteoporotic, we have seen that teriparatide has been useful in both ways, achieving the bone quality formation over there in the injuries also, as well as the overall functional outcomes also. Somehow we have been very happy using teriparatide in these cases, and we tend to use in all elderly people, especially in these kind of a situation when the bone has been so bad, which is requires a build-up.
Great. And so coming to the final question, what's the post-op protocol? When do you decide weight bearing for such patients?
Yes. Considering it is the amount of fixation we have done and amount of the stability, if these are a standard kind of a cage where we have not done much of the reconstruction, this is just like a standard THR we are doing, where we can evaluate the patient very early, and the patient can walk around with minimal weight bearing to start with, and subsequently going over to full weight. But if you have done a reconstruction, we definitely get the patient out of bed, but weight bearing we delay. Usually about 6 weeks, we delay the weight bearing on the affected side. Thereafter, we start the toe touching, and maybe toe touching depending upon the perception of the patients, also depending upon the age and his understanding also, we can start little early. But a lot depends upon the reconstruction which has been done. If it is a stable kind of a reconstruction, obviously they are up and about early. But if it is a kind of which is much supported by the plates and the cages, then we do not want it to be loaded before the fracture start, before the graft start taking over, before the consolidation in that reconstruction starts. So it is much more tailored according to the fracture type, according to the reconstruction type, than as a general rule.
So thank you, Professor Ramesh Sen, for such a wonderful talk. It was very comprehensive and in-depth coverage of the entire aspect of this. I'm confident that everyone who has listened to this webinar would leave enlightened and would take up more challenging cases under your guidance. So thank you once again, and over to Swapnil.
Thank you very much, sir. It was indeed a wonderful webinar. I thank you and Dr. Vaibhav Bagadia for participating in this webinar. And if the viewers have any questions, you can type it in the comments column and we will answer them. Thank you very much and have a wonderful day.
Thank you.